Good afternoon, all of you. I, Dr. Vidhi Tiwari, as a demonstrator, Index Department of Physiotherapy and Paramedical Sciences. Today's my topic is developmental disorder and screening. Developmental delay, defined as a 25% departure from typical performance in greater than two developmental demands. Example, receptive language, expressive language, fine motor, gross motor, social, emotional, cognitive, and pre-academic and behavior. Developmental deviance. In addition to delay in development, physician should also recognize deviation in development. Deviance occurs when a child develops milestone or skills outside of the typical acquisition sequence. An example of this can be seen in conditions such as cerebral palsy, in which the infant rolls over early secondary to increase extensor tone. Developmental dissociation. Dissociation arises when a child has widely differing rates of development in different developmental domains. For example, children with autism often have typical gross motor development but significantly delayed language development. Therefore, language development has associated from gross motor development. Developmental regression. Regression is when a child loses previously acquired skills or milestones, and although less common than the other patterns, should cause the greatest concern sign since it is often associated with serious neurological and inherited metabolic disorder. Of children with measurable delay or disabilities, the most common and least when identified condition is speech language impairment, 70.5% at 30 to 36. Other common conditions are for social emotional disorder, 9.5 to 14.2%. Second, attention deficit hyperactivity disorder, 7.8%. Third, learning disabilities, 6.5%. Next, intellectual disabilities, 1.2%. Next, autism spectrum disorder, 0.6 to 1.1%. Less common conditions include cerebral palsy, physical impairment, 0.23%, hearing impairment, 0.12%, vision impairment, 0.8%, and other form of health or physical impairment, example, Down syndrome, Fragile X syndrome, and traumatic brain injury. Prevalence and significance. As estimated by the World Health Organization WHO, about 5% of world's children 14 years of age under have some type of moderate to severe disability. In India, sources have found prevalence of 1.5 to 2.5% of developmental delay in children under 2 years of age. Evidence supports that early treatment of developmental disorder lead to improved outcomes for children and reduce costs to society. Studies in the US have shown only about 1 by 3 of children are identified prior to school entrance, and a result to miss out on the proven long-term benefits of early intervention. Risk factors for developmental delay. First, history of abuse or neglect. Second, parents with less than a high school education. Third, parental mental health problems, depression or anxiety. Fourth, housing and food instability. Fifth, ethnic or linguistic minority. Next, greater than children in the home. Next, authoritarian parenting style. Example, highly directive, rarely engaging verbally in children's unique interests. Only about 25% of children with developmental delay are detected prior to school entrance, meaning that most children with problems will have missed opportunities for early intervention. Although clinicians are effective at detecting severe disabilities associated with cognition, metabolic, or genetic abnormalities, providers are far less adept to di- discern, discussing the more common conditions because this typically lack overt dysmorphology. Reasons for under detection in primary care: dependence on non-standard administration of standardized screen, including selective items from longer measures and informal milestones. Checklists both approaches lack proof of validity and criteria for making accurate decision. Failure to continually check on developmental progress, clinical judgment, because it tend to depend heavily on dysmorphology and organicity, which are not present in the majority of children and disabilities. Requirement of repeated screening test failure before making a referral due to lack of awareness that quality screening measures are highly reliable and that a repeated screen is likely to yield identically result. Fast optimizing about outcome. Children rarely outgrow developmental problems in the absence of intervention. Discomfort at delivering difficult news, lack of familiarity with tools effective for busy primary care setting. Approaches to screening. First, the three approaches to screening include informal, routine, and focused developmental screening. First, informal screening is based on observing the child during a routine pediatric checkup and asking parents about their concern about child's development. The pediatrician, however, need to familiar with various developmental milestones at different ages. Such as approach is not a very sensitive way of screening, as it is only useful for not missing major delay in a busy office practice. Second, routine formal screening entails systematic developmental screening of all children with the help of standardized screening instruments. However, such an approach is highly time consuming as it requires large number of trained manpower and may not be warranted given the low incidence of developmental problem among low risk population of children. Focus screening. Third, involve developmental screening of the following groups of children. First, children whose parents express developmental concern or in whom teachers and physicians suspect problem. Second, newborn with condition that have known to have high risk for developmental delay. High risk infant needing periodic assessment. First, very low birth weight, greater than 1500 gram, neurogenic condition. First, intraventricular hemorrhage, periventricular leukemia, hypoxic ischemic encephalopathy, Apgar score 0 to 3 at 10 and 15 to 20 minute meningitis, persistent seizures, apnea beyond term, abnormal neurological condition during first week of life, hyperbilirubinemia, symptomatic hypoglycemia with seizures, and septicemia. The concept of at-risk newborn is being replaced by some others authors by the concept of optimality. Newborn with a low optimal score are considered highly likely to develop neurodevelopmental disability later in life. Strategies for early detection. In 2006, the app released a policy statement and algorithm for developmental surveillance and screening in children from birth to 3 years of age. The policy statement recommended developmental surveillance at each health maintenance visit in childhood with the administration of the standardized developmental screening tools for those who have concern by surveillance. It is recommended that a standardized developmental screening tool should be used routinely at the 9, 18, and 24 to 30-month health maintenance checks, regardless of surveillance result. If there are concerns by surveillance that do not yield concern by developmental screening, the child should have early follow-up visits. If the developmental screening is concerning, the child should be referred for early intervention with developmental and medical evaluation plan. The original policy statement did not specifically address older children, but screening at the 4-year to 5-year preventive visit was subsequently recommended for early detection of academic learning problem. If a child passes a screen, praise and reassurance should be provided to the parents. However, if a child fails a screen, it should be explained to the parent that a more comprehensive evaluation is required. In the discussion of a failed screen, it is important to emphasize screen tools are not intended to diagnose a developmental disability, but are instead used as guides to further assessment of developmental delay. Developmental screening tools. There are a variety of screening tests to choose from, many of which are completed by parents and require only a short period of time to administer and score. This questionnaire screening from are convenient as there are no directly administered test items and scoring requires minimal training. The parent's evaluation of developmental status pets is a parent interview from the provides an algorithm to guide a need for referral, more screening, or continued surveillance. The PDS has open-ended questions to parents such as, do you have any concern about how your child understand what you say? It takes under to 10 minutes to complete and has been translated into our 10 different languages. The age and stages questionnaire. Parents completed questionnaire that may be used as general developmental screening tool evaluating 5 developmental domains: communication, gross motor, fine motor, problem solving, and personal adaptive skills for children 5 to 16 month old. It relies on specific questions to parents such as, does your baby laugh? The SQ is estimated to take under 15 minutes. Next, a validated autism screen widely used in the US is the modified checklist for autism in toddler. A 23 items parents completed questionnaire designed to screen children between 16 to 30 months of age. It is available in a number of languages with the validation of this translation underway. Denver Developmental Screening Test DDST. The DDST is used to screen children from 2 weeks to 6 years of age in 4 developmental domains: gross motor, fine motor, adaptive, personal, social, and language skills. The test consists of 5 items, but only those items are administered which are appropriate to the child's age. Each item is scored pass or fail. A delay score is given to an item which is failed by the child that is passed by more than 90% of children in the normative age group. Scores are interpreted as abnormal, questionable, or normal in each sector. The main usefulness of the test is that it is easy to administer and score and does not require extensive training or experience in testing. The DDST is most useful in identifying children with moderate to severe motor cognitive deficits. However, its usefulness is limited in detecting more suitable delay. concern about the inadequate psychometric properties of the DDSD prompted a major revision of the test and LED to development of Denver second. The major differences between the DDSD and Denver second are an increase in the language item, inclusion of articulation items, a new scale, a new category of identifying milder delays, and a behavior rating scale. However, this test has been criticized for its limited specificity and has not been extensively used in the India setting. The DPI-2 is designed to assist a child's development from birth through age 9 years. It is an 86 items inventory which assesses a child functional development age is in 5 domains: physical, self-help, social, academic, and communication. Scenario in India, minimal training required, which allow for ease of administration by house-to-house child development worker. The Baroda Developmental Screen Test for Infant, developed from various scales of infant development and normed on Indian children up to 30 months of age. It has motor and cognitive items and provide an age equivalent and developmental question. It was designed to be a test easily administered by health workers for door-to-door survey as well as clinical practice. The developmental assessment tools for Anganwadi's data designed for identifying toddlers aged 1.6 to 3 years, 1 month, 1 year, 6 months to 3 year, attending Anganwadi government sponsored preschool center in India and administered by Anganwadi worker at risk for with development delay. The data evaluate motor, cognitive, personal, social, and language skills. Trivandrum Developmental Screening Chart TDSC developed from Ballis scale using Baroda norms. It is a 17 items screening tools for children up to 24 months of age requiring minimal training for administration. TDSC can be done in 5 minutes and covers mental and motor development milestone. The Disability Screening Schedule DSS broad-based screen for the identification of major disability in children under 6 years of age. The authors of the DSS design is be distinct from among others as a one-time screening instrument for all major disabilities. It was also created to be easily administered with minimal training. The early language milestone scale ELM scale is a screening test of speech and language development for use with children from birth 36 months. The ELM scale consists of 41 items and covers 3 areas of language function: auditory receptive, auditory expressive, and visual language. This scoring system is particularly useful in high-risk setting and such as neurodevelopmental clinics, audiology clinics, and neonatal high-risk follow-up clinics. Some developmental screening tests show name, age, domains evaluated, administration times, minute, and validity. When concern from potential development and behavioral problem are present either by surveillance or screening, a detailed medical history and physical examination is an essential part of decision making. This should include reviewing result of the newborn metabolic screen, the most recent vision and audiologic screening, as well as environmental screening, example lead testing. Past medical history is important for eliciting risk factors including biological, example, prematurity, genetic, example, Down syndrome, environmental, example, lead exposure, and psychosocial factors, example, maternal education, family income, and marital status. Protective factors should also be documented and may include a supportive family structure, opportunities to interact with other children in a safe environment, and consist expectations with age appropriate limitation. A developmental history reviewing the acquisition of developmental milestones should be taken evaluating gross motor, fine motor, expressive and receptive language, as well as social skill. Family history should include reviewing for developmental delay, learning disability, hyperactivity, and other behavioral and psychiatric problem. Physical examination should include but not be limited to evaluating growth parameters including head circumference, dysmorphology, and a complete neurogenic examination. In evaluating growth parameters, careful attention should be paid to head circumference, looking for microcephaly, microcephaly as an increased growth velocity. This morphologic examination should look at both minor and major anomalies that might explain the etiology of the developmental delay. A neurologic examination should review strength, tone, symmetry, and evaluate for the presence or absence of primitive reflexes. Laboratory test. The recommended laboratory and imaging studied and consultation recommended by the American Academy of Neurology and the American College of Medical Genetics include cytogenic study, DNA testing for Fragile X syndrome, include cytogenetic study, DNA testing for Fragile X syndrome, and microarray based microsomes analysis. Next, in the child with global developmental delay, 3 to 4% of the time, an abnormality may be found on standard chromosomes analysis. For children with an autism spectrum disorder, an abnormal chromosome analysis occur about 7% of the time. Neuroimaging with an MRI and EEG, metabolic screening reserved for these with pertinent history of physical findings, audiologic and ophthalmologic assessment, neurologic examination. Emile Tyson has provided a comprehensive system of neurological evaluation for first 5 years of life and instituting physical therapy program. And Emile Tyson method of neurological evaluation presence of hypotonia is identified by measuring the following angles. First, adductor angle, popliteal angle. Next, dorsiflexion angle of foot. Next, scarf sign. Thank you.